Okay.
Um, I think, yeah, it's just,
Yeah.
you can hear me, right?
Yeah.
Okay. I'm MD PhD, currently working as PGY3 physician at Rutgers Johnson Medical School, New Jersey. We will start our session with brief introduction of our speaker and panelists, followed by presentation by Dr. Mahin. After presentation, our panelists will discuss their personal experience of dermatological manifestation of COVID-19 and management accordingly. Please feel free to ask questions and enter comments. I will keep track of all questions and panelists will answer after presentation. Also, if you want to ask a specific question from a specific panelist, please enter name and we will direct your question to that panelist. This is a 1-hour session and I promise we will finish in time. I will let Dr. Shahid Rafiq talk now and say some comments. Dr. Shahid Rafiq, you're on.
Thank you, Attiya. Assalamu alaikum, everyone. I'm Shahid Rafiq. I'm a neurologist here in Frederick, Maryland, and I'm APPNA MERIT chair. I welcome you all, especially our speaker, Mahin, our moderator, Attiya, and the panelists, especially Dr. Babar Rao, who has been the main person for merit for so many years, being chair also for many years. So it gives me great pleasure to and honor to attend this. As you know, this is not a very commonly presented topic in COVID. Everybody talks about respiratory and nephrology, and sometimes cardiology and neurology also comes, but now we are finding more and more how dermatological manifestation can be there as well. So I am very interested in learning, and so let's start. Thank you.
Okay. So I will start with the brief introduction of Dr. Mahin Alamgir Rao. Dr. Mahin Alamgir is an Aga Khan University graduate of 2013. She is a board-certified internist with advanced training in infectious diseases and currently a third-year dermatology resident at Rutgers Johnson Medical School, New Jersey. Her research interests include skin microbiome, complicated medical dermatology, and developing technology to optimize physician-friendly health systems, including recently developing an AI system to enable patients to easily detect thin rashes that might be associated with COVID, as well as working with scientists from Wuhan, China, the first epicenter of COVID outbreak, to improve physician and patient safety outcomes for future pandemic situations. Mahin, you're on.
Mahin, I think let's, since Mahin is presenting, Attiya, sorry to interrupt, let's introduce Heather and Aisha a little bit, and then Mahin can start. Yeah.
Okay. Dr. Heather Kebengash completed his dermatology residency at the University of Chicago, where he was a resident for the American Society for Dermatological Surgery. He participated in multiple research projects, and in 2010, he was named the honorary research officer at the University of Chicago. Prior to his residency at the University of Chicago, Dr. Bengash completed an internship in internal medicine at the University of Connecticut Health Center. He then pursued a clinical and research fellowship in lasers under the guidance of Dr. Omar at the Connecticut Skin Institute in Stamford. Dr. Bengash completed his medical school at the Aga Khan University Medical College in 2008.
Heather, would you like to say a few things, please?
Yes, thank you so much, and for giving me the opportunity to be with such a distinguished panel. Very honored and very humbled to be here, and looking forward to this wonderful presentation. Thank you.
Okay, Attiya, since Aisha is not here yet, she will join.
Okay.
I think we can let, I'm Babar Rao, everybody. I don't want to say things about me, but we will be talking in between the sessions. So I think we can let Mahin say a few things that you want to say about you and get started.
Dr. Roy, I have your introduction as well.
Okay, you can do that. Okay.
Dr. Babar Rao is a board certified in both dermatology and dermatopathology and is a leading authority on pigmented skin lesions, as well as a pioneer in dermoscopy and confocal microscopy. Dr. Rao has completed residency training and fellowships at the University of London, UT Southwestern, New York University, and Cornell University, and currently serving as a professor and associate clinical professor of dermatology and dermatopathology of the Department of Dermatology at Robert Wood Johnson Medical School. Dr. Rao is also a clinical associate professor at Cornell College at Cornell University.
Thank you, Attiya. Mahin.
Assalamu alaikum, everyone. Thank you for giving us the opportunity to present this topic and for being here today and taking out so much of your precious time. I'm going to start without any further delay. So today, let me just share my screen and please let me know if you can see my screen.
Yes.
You can? Okay,
yeah.
Great. So let's start. So I'm going to be talking about COVID-19, dermatological manifestations and management. So a brief introduction of viral exanthems. We thought it would be appropriate to do a brief overview of viral exanthems in general, because COVID-19 is part of this broader topic. So when a patient walks in and as a physician, you're trying to evaluate if they have a viral rash, there's a few questions you want to ask. You want to know their age, what their accompanying symptoms are, what the risk factors might be, such as immune compromised status, pregnancy, are they on any biologics, are they under chemotherapy, the incubation period of their symptoms. So when did the illness start versus how long have they been feeling sick, when was their last contact with someone who could have given them this illness, any recent travel history. The vaccination status is especially common when you're considering people who are coming from certain geographical regions. Exposure history, if they work in a hospital, if they work in a nursing home, if they work in a high-risk situation, as well as where they're coming from. And all of these factors help us to make an understanding, sort of give us a broad clue of what this could be. Can we do an early clinical diagnosis? And it's especially important when you don't have the test necessary. So for example, in the early phases of the COVID-19 outbreak, when we were seeing skin rashes and people with atypical pneumonias, it was really hard to get them tested because the tests were just not available. And at that point, early clinical diagnosis becomes key, because when you think of, if you're not thinking about it, you're not going to tell them to isolate. So it's always good to have it in the back of your mind, and it ends up being a good public health measure. So when somebody walks in and you're thinking of, is this a viral rash syndrome? Yes or no? You kind of go down, well, if it's no, then you're like, maybe it's mosquito borne or it's a tick infestation. You try to, it's a different workup. But if you're thinking of, yes, this is a viral, this could be a rash that's associated with a viral disease, you want to look at what the rash actually looks like. Is there a vesicular pattern to it? Do they have systemic symptoms with it? And then you want to start looking at the broad patterns. So are the hands, feet, and mouth involved? Yes, you could think of, if that's the case, you could think of more the varicella viruses, the herpes viruses. If you see that there's a papillopurpuric gloves and socks syndrome, where their hands and feet are involved and they have petechial rashes, you think of B19, you think of CMV, measles, HHV6. You could have AGEP, which is this wide, sort of diffuse pustular rash, which is mostly induced by drugs, but then also there's a link with adenovirus, CMV, EBV, and hepatitis B. There's geonotic crusty syndrome that we see in children. And over there, you want to think of EBV, CMV, B19, influenza. So this is where the vaccination history, the age of the patient, and the exposure history become very important. Because if you have this additional data and you're looking at the kind of rash, you can kind of break it down to maybe 3-4 viruses that you may be dealing with. And then you can go ahead and add more serologic tests, or if you want to quarantine them, or if you think they need an admission, you can refer them to the hospital. Also, if someone's coming in with headache, periorbital pain, and a purpuric petechial rash, you're thinking of dengue, especially in South Asia. So that becomes an important, even in Thailand at the beginning of coronavirus, that was people thought that they were dengue rashes, but they were actually COVID rashes. If there's arthritis, you're thinking of B19, chikungunya. If there's encephalitis, you're thinking of Japanese encephalitis, especially if there's travel history and they haven't taken the travel vaccines that are needed. So this is just, a broad sort of algorithm to keep in mind when, as a dermatologist, you're approaching a patient with a possible viral rash or a bloodborne virus exposure, etc. I thought it would be good to review it since, it's sometimes maybe we haven't reviewed these things in a while. So I'll focus more towards coronavirus now. It was first isolated from the nasal cavities of humans in 1960s. There's 4 types: alpha, beta, delta, and gamma. They're zoonotic, so they're primarily found in animals. They actually infect a wide variety of animals, but then sometimes they jump species and they can jump to infect humans. There's 7 main subtypes of the human coronavirus. They're all single-stranded positive RNA viruses with a 32 kilobase long, largest known virus genome. Why that's important is because it's a 32 kilobase long genome is very susceptible to genetic mutations, and that helps this virus jump host to host. So the coronavirus 19 that we're dealing with right now is a beta virus, and there's different theories about where this virus originated from. The diagnosis of COVID-19 primarily depends on history, clinical signs, so fever, fatigue, dry cough, anorexia, dyspnea, rhinorrhea, loss of smell, loss of taste, vital parameters, temperature, pulse oximetry, saturation, lab values that may show lymphopenia, increased acute phase reactants such as CRP, ESR, LDH, and D-dimers, as well as radiography such as X-rays and chest CT scans. And then comes the role of nasopharyngeal and oropharyngeal swabs for RT-PCR to confirm the diagnosis. There are now emerging tests which include the reverse transcription loop-mediated isothermal amplification, RT-LAMP, antigen testing. So instead of testing for the capsule or the capsid protein, you can test for other viral particles, as well as lung ultrasound. All of these tests are under development right now. They're not as sensitive and specific for as the main PCR that we're using. So they remain under experimental study at this time. The epidemiology of this virus is different in adults and children. It's also different in different regions of the world. So in China, 87% of the cases were between ages 30 to 79, and 3% were 80 years and older. 51% were male. In Italy, the median age and prevalence of comorbidities was higher, also because they have an older population. It's the second oldest in the world after Japan. So the demographics change. In the UK, the median age is 73 years, and males again account for about 60% of admissions. In the US, older patients ages more than 65 account for 1/3 of all the cases, and about half of the hospitalizations and more than half of all the ICU hospitalizations, with 80% of deaths occurring in people 85 and above. In children, they're less likely to be affected than adults, and this holds true for all geographic regions, and they account for up to 5% of confirmed cases, depending on the geographic location. So in China, about 2%, Italy, 1%, Spain, 0.8%, US, 1.7%, with the median age being 9.6 years, and males, again, being at a higher risk. So how does COVID or the coronavirus cause injury? There's a multifactorial pathogenesis of injury that is thought to underlie it, which includes direct viral cytopathic and cytotoxic effect, the starting of an inflammatory cascade and the cytokine storm, as well as microvascular angiopathy and thrombosis leading to multi-organ failure. All of these can have distinct phases, and clinical presentations can vary depending on which stage of the illness the patient's in at that time. So as dermatologists, as epidemiologists, infectious disease doctors, pulmonary doctors, what we like to do is kind of think beyond what's happening. So we want to know which viral rashes are well established with regards to pointing to a specific viral etiology. So for example, slap cheeks and B19, this may be considered specific to the B19 virus, but how specific really is it? And should we be open to thinking of new diagnoses when we see something that looks like a B19 rash? These rashes have mostly been established by epidemiological analysis, not always serologic analysis. And in ID, especially, a lot of the diagnosis rests on serologic analysis. Do you or do you not isolate the bug? We should question the increased prevalence of certain rashes compared to the baseline. So there's been an epidemic of COVID, and an epidemic of COVID goes with it. And one has to think why certain rashes are being seen more than the usual. A lot of people have been seeing zoster much more than usual, urticarial rashes much more than usual. So one has to question why that is happening. We should also wonder about unexpected disease courses. So urticarias that you're trying to treat, but they're just refusing to get better, even with systemic treatment. Pernio that you're trying to treat with established treatment algorithms, but it's not getting better. So you should think, well, am I missing something? Is something else going on? What do dermatologists need to know? So there's 4, 5, maybe 6 main patterns of injury. When it comes to coronavirus rashes, there's the morbilliform rash, pernio-like lesions, macular erythema, vesicular rashes, urticarial rashes, and livedo reticularis or vasculitic rashes. So I'll go briefly into each of these, and I'll show you some pictures so that you can begin to classify them broadly. This is a morbilliform rash that most likely will present on the trunk and extremities of patients, and most patients with this rash tend to be in the young to middle-aged age group. When they did a retrospective analysis, these rashes had sort of like, they were in the middle when it came to prognosis. Prognosis could be good. These people could stop here and get better, or they could go on to develop more severe disease. So this is certainly one of the rashes. If you see it on your patient, you want to keep an eye on them in terms of disease progression and symptom progression. These are more examples of morbilliform rashes. You can see these impressive widespread rashes basically taking over the entire trunk. In the one on the side, you can see some scaling and some evidence that this is now beginning to resolve. From a bright red, it's getting this browny tone, which means it might be on its way out. So this patient actually might be on their way to getting better. Urticarial rashes, very commonly seen in young and middle-aged patients, very commonly seen on the trunk and extremities in COVID patients. And you can see that it's quite widespread. It's also seen in babies. All of these patients, by the way, the pictures of the patients who have been included, they all have confirmed COVID-19 by serologic testing. So these are not patients where the differential diagnosis was an open-ended question and we didn't know what was happening. In babies, again, you can see it can kind of pretty much affect the entire body, including the genital area and hands and face. Pernio-like lesions usually will involve the extremities, hands and feet. Distal extremities, you might see erythema, you might not see erythema, depending on what time they're presenting. You might see the entire extremity being affected by it. You might only see just the tips, just the distal ends. You might have pain, you might not. You might have paresthesias, you might not. You might have edema and swelling, you might not. So you have to keep an open mind when you're looking at pernio lesions. Most case series have examined them to happen in young, healthy, middle-aged, healthy people who have otherwise been asymptomatic, usually towards the end, not the end, towards the later course of the illness, and usually those people have had a better prognosis, have tended to have tended to recover from the illness without very many severe manifestations. So if you see this in a patient, yeah, maybe, you know, they have COVID-19 and they're not happy to hear that, but you can share some information that this is usually seen in people who will go on to get better. But what's important is going over the quarantine and isolation measures that I'll go into later on. These are some more pictures of hernia. Like I said, some of them may be affected, not all of the toes have to be affected. So you could have only one toe affected. Specifically, if you look at the picture on the top right, you see that only the third toe is affected. But you can see prominent swelling and a prominent violaceous rash close to the distal end. You might have just petechiae, or you might have small, almost like vesicles forming on the extremity. So these are all presentations that might accompany pernio-like lesions. This is a study that came out of Connecticut, I believe. This was the first case of a biopsy proven pernio associated with a COVID-19 patient, and you can see all five of the toes are affected. So I wanted to show the different findings. So if you look at panel B, you'll see that this is a punch biopsy, and you'll see a dense lymphocytic perivascular infiltrate, and it's superficial, but it's also deep. And then panel C is a higher view of which will show some. Over here, if you can see my arrow, you're seeing epidermal sloughing. So actually, if you look at panel A, you can see a blister here forming at the fifth toe. And that is representative of the epidermal necrosis and the subepidermal cleft that is giving you that clinical blister in this patient. This is obviously happening because there's widespread necrosis of this part of the skin. And that is because they actually saw a microthrombus in a small blood vessel, which is in the bottom right. You can see in under magnification, the entire vessel is infiltrated with a lymphocytic infiltrate, and it's showing that it's thrombosed. So this is one of the early biopsies that were done on these patients, just helping us to develop a deeper understanding of what's going on. So pernio with endothelial damage might portend a good prognosis, but it could also, if endothelial damage on its own could go the other way, as many of us know. So despite the high number of cases of chilblains seen during the COVID-19 pandemic, a definitive causative role for SARS has not been proven yet. So they don't know if it's a definite causative role, but they continue to explore this. Different pathogenetic hypotheses, including coagulation anomalies, interferon release, and external factors have been proposed. There's a study that just came out of Spain, which wanted to look at that question, like, is this just a chance observation that we're seeing all of these, or is there an actual role? So they were able to demonstrate SARS-CoV-2 particles in endothelial cells of skin biopsies by IHC as well as electron microscopy. So they did a case series of these patients where they took their biopsies and they ran the stains on them. And they concluded that virus-induced vascular damage and secondary ischemia could explain the pathophysiology of COVID-19 chilblains, supporting the finding that widespread endothelial infection by SARS-CoV-2 could have a pathogenic role in the severe forms of COVID-19. Histopath showed variable degrees of lymphocytic vasculitis, ranging from endothelial swelling, endotheliitis, to fibrinoid necrosis and thrombosis. So basically, if this is happening in the skin, this is what's probably happening elsewhere, is what they're trying to say. Purpura, superficial and deep perivascular lymphocytic infiltration with periacrine accentuation edema and mild vascular interface damage were also seen. SARS-CoV-2 immunohistochemistry was positive in endothelial cells and epithelial cells of eccrine glands. And this goes back to one of the earlier slides where we were talking about the multifactorial pathogenesis. So this helps us understand that direct viral cytopathic injury does have a role to play. And then comes the cytokine storm. coronavirus particles were found in the cytoplasm of endothelial cells on electron microscopy. And I think eventually, when we have time for this, we will be able to develop maybe some antiviral drugs that can directly interfere with the cytopathic injury. There's also vesicular rashes. They're more seen in older patients, more seen in patients who will develop moderate to severe illness. So you can see this is a vesicular rash, very much like a hemorrhagic exanthem that is seen with chickenpox. So it's really rare to have chickenpox in an otherwise immunocompetent elderly patient. And if you're seeing this in somebody who has had a clear history of chickenpox as a child, or they have serologic evidence of immunity to varicella, and you're seeing a primary chickenpox-like rash, you should really be questioning why do they have it, especially if they're not immunocompromised. Again, you can see this is a relatively younger patient, and you can see discrete prominent vesicular lesions on the extremities of this patient. And then we move on to the more severe forms of COVID's manifestations, the lividoid or vasculitic rashes that most of you might have seen while rounding on your ICU patients, on your super sick patients. And they can start at one point, but then progress to kind of pretty much involve the entire body, the buttocks, the trunk, the extremities, and from small to large confluent vasculitic rashes. This is a case series that came out of China, and these are 4 different patients. And you can see total necrosis and gangrene, actually, of the extremities, the feet and hands in these 4 patients. And they're all ICU admissions. They all had severe pneumonia. Most of them were intubated. I don't remember the exact percentage. This is the early days where, intubation was, I think, more common. And none of these patients survived, unfortunately. So the reason I included these slides and I wanted to talk about them in more detail is if you're seeing one of these rashes on your patients, that means they're very severely ill or they're going towards severe illness. These are pictures from the same case series published by Zhang, which looked at 7 patients in Wuhan. And again, you can see that it's extensive involvement of the extremities with gangrene, and you can only imagine what the clinical outcomes were in these patients. You can also have erythema multiforme-like rashes. They can be quite extensive, happen in young and middle-aged patients mostly, and we don't understand yet what kind of clinical illness they might predict, because there's not as many, so we haven't yet understood the link if they're going to happen in mild illness or serious illness. So this remains an open-ended question. As you can see in the top center, you can see sort of like the multiple colors forming, the dusky center, and then sort of the urtic area around it, the targetoid appearance. So if you see something like this, you might want to check for, repeated HSV infections, but say they don't have any of that, or you do serologies and they're IgG negative on HSV, you might want to think of, is this drug or is this corona at this point? You can have rashes resembling EED, which is a vasculitis with not much known about its pathogenesis, except that it's linked to certain infections and non-infectious diseases. This is, again, pictures of patients who have the purpuric manifestation of COVID-19, again, linked to, obviously, this is involving the vessels. This is, like I showed you in the biopsy specimens, most likely underlying multiple micro thrombi. So you're expecting more severe disease in these patients. This is a case that was just published in JAMA Derm, where they saw a petechial skin rash associated with a severe coronavirus infection. And you can see how the exanthem consists of macules, papules, and petechiae, but it's sparing the folds. So it's sparing the genital folds, but it's present on the extremities, on all of the pressure areas, the trunk, and the legs. And what was striking about this rash was when the ER physicians first noticed this, they thought it looked like the purpuric rash seen with B19. So then they started, obviously, corona being at the top of everyone's differential right now, they started their investigation. Physical examination revealed this confluent rash in a symmetric periflexural distribution affecting the buttocks, popliteal fossa, proximal anterior thighs, and lower abdomen, and no lesions in the crural folds. There were also no acral or mucosal lesions. He had a lymphocyte count of a 750, a CRP of 1.7, and a D-dimer of 0.68. So while he was definitely ill and more towards the severe side, he wasn't in the critical side of COVID-19's illness. So he did recover and was eventually discharged. They did a 5 mm punch biopsy, which showed superficial perivascular lymphocytic infiltrate with abundant red cell extravasation, which gives the purpuric look that you can see, as well as focal papillary edema, along with focal parakeratosis and isolated dyskeratotic cells. They did not see any features of thrombotic vasculopathy. This is the biopsy specimen from this patient, which shows the red cell extravasation, the dermal papillary edema, as well as the scattered dyskeratotic keratinocytes. So viral proteins from parvovirus B19 have been found within the endothelial cells of dermal vessels and could be implicated in the pathogenesis of purpura. So the question is, can SARS-CoV-2 affect the skin in a similar way? Some histologic features in this case, that is mounds of parakeratosis, mild spongiosis, extravasated erythrocytes, overlap with those of PR, which is also suspected to have a viral pathogenesis. So it's important that we do biopsies on these patients. It's important that we begin to understand these patterns. And it's important that we do detailed serologic testing, as well as stains, so that we can understand where and how the virus is actually affecting these patients. I also wanted to go over enanthems because they are also being seen. And a lot of the time when a dermatologist is consulted for a rash, the question is, oh, is this a viral infection or is this a drug infection? Drug eruption. Because they're very common, and those are our two differentials for things that look similar. But enanthems are important because the presence of enanthems can kind of very much lead you to be specific about a viral etiology. So enanthems, such as these petechial spots seen on the lower lip, on the hard palate, these are COVID-19 patients. So we don't have a specific pattern yet, like Koplik spots for measles, but we are beginning to see that they can affect the mucosal surfaces. So definitely, if you're doing a skin exam on a patient, definitely look at the mucosa. You'll obviously be looking at their extremities. So this is an important clue to help distinguish between drug and viral entities. So look at the oral cavities. This is a study of 21 patients from a tertiary care hospital who had a skin rash and COVID-19 confirmed by RT-PCR. Of 21 patients with COVID-19 and skin rash, 6 of them had an enanthem. So 1/3 of your skin rash patients might have mucosal involvement. It was macular in 1 patient, petechial in 2 patients, and macular with petechiae in 3 patients. And it was located in the palate in all of these 6 patients. None of them presented with an erythemidovesicular enanthem, and the mean range of presentation was 12.3 days. So relatively, I would say, mid-illness. Clinical correlations and patient outcomes. This is evolving data. That's
sorry to interrupt you, Mahin. You get 3 more minutes to finish.
This is evolving data. The question is, should an intervention be made when a rash portends a poor prognosis? So pernio may appear late, signal a better prognosis, but libido is associated with poor outcomes and ICU admissions. It is associated with DIC, multi-organ thrombotic events. And like I said, in the pictures that I showed you, there was very high mortality, 11%, which is 7% and 7 times higher than the usual mortality. This is again, a necrotic hemorrhagic bullous rash seen in a patient, unfortunately, who presented like neck fash, had COVID-19, was intubated and did not make it. He was only 29 years. So different patterns may be associated with different severities. It's important to recognize these rashes for public health measures because you can isolate and quarantine them per recent guidelines, which keep changing. Treatment protocols for mild illness, we give prednisone for pernio-like lesions, aspirin for pernio-like lesions, topical and PO steroids for urticarial or maculopapular rashes. For EM-like lesions, you want to give topical steroids, but you always want to rule out other etiologies with biopsy or serologic tests. Severe illness, if it's livedoid vasculopathy or purpuric rashes, there is a role for anticoagulation and systemic steroids like dexamethasone. The gaps in knowledge that we still need to address include, is there a direct viral cytopathic effect? If yes, can antivirals help? Can skin signs subphenotype patients leading to changes in management? What are the signs that are sensitive or specific enough for the diagnosis? Are any skin signs clinically important in the acute management of patients? What is the correlation of viremia to the onset of morphology of rash? And eventually one day when we can understand the dynamic viral road and its reference to skin rash, it can become a vital clinical clue for clinicians to determine the optimal timing for a rapid diagnosis. So when to do a serologic test. All right, thank you.
Well, excellent job, Mahin. You summarized it very well. I think, Attiya, at this point, maybe we can have Heather or Aisha, if she's here, say a few things, and then we'll take questions.
Okay, sounds good. We have a couple of questions. So Dr. Bangashi, want to start first?
Yeah, sure. Thank you for a wonderful presentation, Mahin. Specifically, let's start with the first question. Is the rate going down effectively as the less virulent strain a factor? I'm not particularly aware of the strains that are circulating in Pakistan. I don't even know if we have the sort of the exact data to comment on that. But as far as the skin goes, I think the typical rashes that I'm also looking for being in the community are sort of more of these morbilliform eruptions, and I'm seeing a lot of these purpuric eruptions, particularly the COVID toes, although I've seen involvements of the, the fingers as well. So, but definitely, I think this is a very evolving concept. We're getting more data. In fact, we're getting a deluge of data regarding COVID, because I think the average time from any case report or case series that's submitted and then it's accepted for publication is 6 days now. So I think we really have to tease out what is actually related to COVID and what is just being published and thrown out there. There is a great registry out now. The American Academy of Dermatology and the International League of Dermatological Societies has a great registry where, I think it's good to add those cases in to get a better sense of exactly what is actually related to COVID and what is sort of more of coincidental rashes or something that might not be related to COVID at this point in time.
So Attiya, maybe you can introduce Aisha one more time. She just joined, and if she has any comments, or we'll take a question as we go.
Sure. Give me 1 minute. So we have Dr. Aisha Sethi here. She was born in the United States and educated in Pakistan. Dr. Aisha Sethi graduated from Aga Khan University in 1999 after completing its Bachelor of Medicine and Surgery program. The same year, she traveled to US as a visiting medical student for 2 months of electives and subsequently received NIH Dermatology Research Fellowship from her host university. She completed her research fellowship and residency from Yale Dermatology residency program. Dr. Sethi, you're on. If you can please introduce yourself and talk about your experience, COVID manifestations.
Okay, thanks, Attiya. Thank you to Dr. Rao and Heather and Mahin. That was a great talk. I'm in my car, everyone, so I hope everybody can hear me okay, because I have a house showing, so unfortunately. So I think there's a few things to know about, I think, at this point about this virus. I think the most common presentation that we have seen, also we gathered data from Europe, from Italy, and from the French. Urticaria and viral exanthems are one of the most common presenting signs in adults. And everybody heard about the COVID toes that we were seeing in children. So as most of you know, this virus puts you in sort of a prothrombotic state and hypercoagulability. So the skin manifestations that you see as the virus progresses, you can get really firm purpura. But I think for the most common skin signs at presentation, so what would the primary care or the internist who's seeing patients, outpatient, when do they need to think of COVID? And I think that would be the top three things would be a viral exanthem, something that looks like pityriasis rosea, urticaria with fever, and I think vesicular rashes are not as common. Somebody had asked a question if shingles, I think, was more common in COVID patients. We don't know that. We do know that if you see shingles in somebody less than 40 years of age, they have to be, worked up for immunosuppression. So I think basically those are the things I would say are the most common presenting signs at this stage. Thanks, Attiya.
So Attiya, you want to take any questions, more questions, or anybody in the panel? Yeah.
Yes, we have more questions, but Dr. Rao, do you want to talk about your personal experience? If yes, you're on. Otherwise, I'll take questions.
No, let's just take questions. Otherwise,
okay,
yeah.
2 questions. Dr. Bangash and Dr. Sethi already answered first 3 questions. I'm going to move on to the 4th one. It's from Dr. or Professor Zaki. Are COVID-19 patients more likely to get shingles? That's Dr. Sethi already answered, so I'm sorry about that. So the next one is, are these skin lesions accompany the typical symptoms of COVID-19? Yes.
So I think Mahin summarized that. So there are really no specific lesions, but certain lesions are more prevalent in COVID-19 patients. As Aisha said, basically urticarias are very common. And then next common group is like purpuric lesions, and then the vesicular one and COVID one are less common. But there are 5 or 7 different types, which Mahin put a slide earlier. Any of them could be seen. So what I've been doing is, if I have a patient which never had an urticaria before and urticaria which just not going away, then I am requesting, COVID and telling them to just stay home until we find that out. So yeah, there are lesions which are not specific to COVID, but very common in COVID. Yeah.
And I think just to add on that really quickly is the point is, like, usually as far as we know, herpetiform or shingles-like lesions only form when people have shingles, like varicella zoster-induced shingles. But now for the first time, we're seeing herpetiform vesicular lesions forming in patients that have another viral etiology. I think that's what's important to recognize, that this could be shingles, bread and butter, or this could be COVID-19.
Okay, thank you, Dr. Rao and Mahin. So next question is from Dr. Pasha. How long do the rashes last?
It depends on the rash.
It depends on the rash, but on average, like urticarias, if untreated, could last, like I've seen, 2 weeks on average. But minimum these urticarias are like 7 to 10 days. If untreated, that could be longer. In reference to COVID toes, they still, most of them, like at least more than 2 weeks on average. Aisha or Heather, you want to comment?
Yeah, I think one of the things is that we're still finding out more about this virus. Now we know that there are some patients who are called long haulers, and the long haulers continue with symptoms and with generalized symptoms for weeks to months after getting the initial infection and keep on testing positive. So if urticaria lasts in a few weeks, then I think it would be in the chronic urticaria category. But I think what's been reported mostly with acute infection is the urticaria that Dr. Rao was describing. So that would be acute urticaria. So that is correct. That's what's mostly being reported. And it's very good. I think somebody had mentioned if you do have a case, please send it in to the registry, to the AAD registry. We can get more information that way. Thank you.
Okay, so the next question I think I will direct to Dr. Sethi because she answered part of that question already. So the question is, a pregnant woman had rashes confluent in nature but was negative for COVID-19. She is given the treatment you just mentioned and she was well again. She had some rashes 1 week later. No past history of any skin problems.
I'm sorry, the patient was pregnant and got COVID, Attiya?
Patient was pregnant, but she was negative for COVID-19. She is given the treatment, I think Mahin mentioned in the presentation, and she was well again. She had the same rashes 1 week later. No past history of any skin problems.
Well, I mean, in pregnancy, you can get a whole host of other dermatoses. So it depends on what kind of eruption it was. You can get urticaria, you can get some blistering diseases specific to pregnancy. So I think definitely you need a biopsy. And if you can, if it is vesicles or blisters, you need to send an immunofluorescence if possible, because pregnancy by itself can cause a whole, host of other skin conditions. And of course, COVID can complicate that on top of that.
Also, I would just add that maybe false negative, because I have seen that case as well. We should always keep that in mind, right? So, and especially if she was well after the treatment, so that's possible.
It's a really good point, yeah.
So the next question is, what are any proven treatments for these lesions? Dr. Bengash, Dr. Rao, or Dr. Sethi? Anyone?
So
go ahead, Heather.
Yeah. So really, in terms of I think what we're dealing with in terms of etiology, if it's sort of COVID toes or anything like that, most of these lesions have resolved on their own, even just without treatment. I think up to 8 weeks out as well. They sometimes last and they go away, but I usually go by what I would treat the primary lesion with anyway. If it's more urticarial, then I would sort of target that with antihistamines. But again, these treatments, they haven't been studied like that. I think most studies just mention sort of topical steroids or sort of vague treatments like that, because a lot of these studies have also been sort of reported by other specialties too, and even the rashes are treated by other specialties in patients. So we really don't have that data, but I would probably focus on making sure that you're treating the underlying COVID symptoms and making sure the patient's doing okay, and then B, trying to focus on the exact etiology, if it's urticarial or if it's more morbilliform, sort of approaching it that way.
I think Mahin had a slide where she showed also, but basically it is from antihistamine, topical steroids, aspirin, maybe systemic steroid, and then it's a serious patient, maybe anticoagulants, but those are the patients are inpatient, not at home, but at home, topical steroid, antihistamine, and maybe oral steroids, given which type of lesion we are dealing with.
Okay, so the next question is, thank you so much for an amazing session. I have a question not related to COVID, but being a dermatologist was always my dream. But they say but they say it's very hard to get in derm in USA for a Pakistani IMG. I would really appreciate if you can shed some light on it. Thank you so much. I am from Alamgir Medical College, Lahore.
I think this is a good question, relevant question. So me, Heather, Mahin, Attiya, Aisha, we were all foreign graduates. Was it difficult to get in? Yes, but I let some younger people talk about it. Maybe Heather, you can talk about it, how an IMG can get into derm in this country.
No, nothing is impossible. That's what I've learned, especially if you have amazing mentors like Dr. Rao, Dr. Sethi. I think if you're really interested, then there are always ways. Just, you know, have to sort of focus on it, work hard, publish a lot, and sort of put in the time. And I'm happy to answer any sort of questions that you might have. You can always email me, and I can share my email as well.
Thank you. Thank you.
The next question is also related to the above one. It's moved actually. So what precautions are each of you taking personally when seeing patients with suspected COVID to prevent bringing it to home to you and your families?
Mahin, you can talk. What I do is when I leave the clinic, I leave those clothes there and try to change the clothes and get home and maybe shower. And when I'm with the patient, obviously mask and gloves. And what we have done in our offices is like we don't letting patients sit in the reception area. They are in their car or they're standing, then they get a phone call, go to room 3 so that they're not sitting in the reception room. We go in, do a quicker visit or a quicker procedure if it's, and where, you know, all the precaution. But before you go home, change. And if you have a facility where you can shower before you meet rest of your family, that's a good idea. But I let inpatient people talk, like Attiya and Mahin, you're doing consults.
Yeah, so if it's a suspected COVID-19 patient, then we're definitely wearing N95s, confirmed definitely N95s. And if it's a regular outpatient visit, then even surgical mask and face shield is okay. At least, like, you know, every hospital has its own policies. And but if you're operating on a mucosal surface, so if the nose or lip is something we're operating on, then we're wearing an N95, and we're screening all our patients for COVID if we are going to have them in the room for even longer than 2 hours or 1 hour. But otherwise, standard universal protocols: gloves, hand washing, gown.
Okay, so next question is how to distinguish a chickenpox rash from COVID rash in children under 5 years?
I don't, yeah, I'll take that. So chickenpox, the vesicular portion of chickenpox tends to be more truncal and on the trunk. And in chickenpox, the vesicles tend to be in different stages of evolution. That means some will be crusted, some will be vesicular. In children, so far, chickenpox like rashes, well, in this country, a lot of, in the United States, a lot of the children are vaccinated against chickenpox. So you don't see chickenpox very commonly in the US. So that's one important point to make. So if you're seeing a vesicular rash here in the United States, that's truncal, I think COVID would be in the differential. As with any rash, I think right now COVID would be in the differential. Yeah. But children here are usually vaccinated, so you don't see a lot of chickenpox here. But when you're in Pakistan or when I practice in East Africa, you see lots of chickenpox. So I think you have to keep it in mind. If you see a vesicular eruption on the trunk with a child who is febrile right now in the throes of the pandemic, you probably have to keep COVID in the differential. But most likely it will be chickenpox if you're seeing it in Pakistan and multiple family members have it.
Yeah, I think at some point we also need a specific webinar for derm manifestation in kids. That would be really interesting as well. We don't see much in US as well. So we are left with 2 minutes, and last question. This question is specifically for Mahin. How an oral prednisone or dexamethasone safer and more effective in pregnant women presenting with urticarial rash, if COVID or otherwise?
Safer than what? Sorry.
Like just systemic steroid and pregnancy, yeah.
And specifically in pregnant women, if
I think the question is about, is it more effective in pregnant women with COVID rash and urticaria rash? So COVID, urticaria, and pregnancy. Would you consider steroid safe or not?
It depends on which trimester of pregnancy they're in. Actually, if they're in the third trimester, you try and avoid systemic steroids and you lean towards topical steroids. In the first and second, systemic steroids are considered safe. Also, the studies that were done with dexamethasone in the UK did not include pregnant patients. So it would be an extrapolation of that data if you were using dexamethasone. Again, the dexamethasone in those patients was not being used for urticaria. It was being used to treat the cytokine storm. So we should really, like Heather pointed out, there's a lot of data and it's a deluge of information, but understanding what drug was used where in what patient population is important before we take these findings and begin to apply them with a broad brush. That's
sorry,
one antihistamine that's safe to use in pregnancy, just so I'm sure a lot of people here know that already and is widely available in Pakistan, is Zyrtec. So that's category B, or citrazine. That can be safely used in pregnancy if you're seeing urticaria.
So I think, Attiya, the questions will continue. I want Shahid to say a few words. Shahid Rafiq is the chair of our APPNA MERIT. Shahid, if you want to say a few words before we conclude. Okay. If Shahid Naz here, I'm also co-chair of APPNA MERIT. So I would like to thank you, everybody, especially the panelists. Mahin, excellent job. Attiya is at a wedding. I forced her to moderate the session. And then Aisha is in car. Thank you. And Heather, thank you. On a short notice, you all, teamed up. And also, really, we could have brought any panelists from USA or anybody, but for me, it was important to show that we are all foreign graduates and we are doing this in the United States. So you all can definitely do if you are interested, some resident students there. But if you have any questions, please contact us through APPNA MERIT, or you can contact us directly. Our emails are in this chat. Otherwise, you can all write me. I will forward it to one of these panelists. My email is my first name, last name at Gmail, which is babarrao@gmail, and shoot emails and we'll guide you.
And also I wanted to thank Heather for all his feedback and help with the presentation. Thank you. It's always nice to have an AQ.
Yes, and we maybe will come up with another session. And if there are dermatologists here from Pakistan, there are some, I think, on every Friday morning at 8 a.m. New York time, which is usually 5 p.m. Pakistan time, we do skin pathology sign-outs, and basically they are live cases which none of us have seen before. So if any of you want to join, please shoot us an email. We'll put you in the group. With that, I think, Attiya, if there is no question, we will release people. Yes.
Thank you so much, everyone.
Thank you.
As promised, everybody get a release in 1 hour. Have a good day. Thank you, Aisha.